Welcome, everyone. Today's webinar is talking about longevity, and I framed this as the 5 top tips for maximizing longevity. For those who don't know me, my name is Liam Finlay. I'm an internal medicine specialist. I maintain a hospital-based practice. I'm also a specialist in high blood pressure or hypertension. Some of you may have met me at the Toronto Hypertension Clinic. I'm also passionate about longevity and have recently founded this thing called Almira Medical. So it's a private medical clinic focused on longevity, which we'll speak more about near the end of this talk. This webinar is set to run for give or take about 90 minutes with some of the time near the end of it left for questions. Feel free as we go along to leave questions in the chat. And I will try my best as near the end of the talk to address any questions that come up. All right, so topics for discussion today. We're going to recap some basics in longevity to start off with, and then we'll get into the meat and potatoes of today's talk, which is my 5 top tips. And that's my kind of personal take on things in terms of maximizing longevity. And then last but not least, talking about Almira Medical and what services we provide. As a disclaimer, this talk is intended for general educational purposes and is not intended as a replacement for individualized medical advice. So some longevity basic concepts. So first concept is talking about lifespan versus health span. So lifespan is how long we live in the earth. And this is essentially the current primary target of our healthcare system. So trying to expand how many years that people live. But of course, we want health span as well, which is living essentially free of disease, free of disability, functionally active, like these people in the bottom right, for example. And I would go so far as to say that this is currently undervalued by our healthcare system and by the medications that we're often prescribing. I think there should be greater focus on prioritizing health span, aka living healthier or more functional for longer. And a few reasons for that as well. Or living a life with limited health span is really no great life to live. Once our health span starts to really dwindle, death is often nearby. And the things that help us remain healthier, more functional for longer, things like exercise, nutrition, sleep, cognitive stimulation, what I would consider kind of lifestyle interventions. These are actually, when you look at the statistics, the things that help the most when it comes to extending our lifespan. So putting the focus on health span is where the money's at. Here is a chart that somewhat represents what we've just said. So our current healthcare system and the average in a Canadian here is in green. So earlier in life, on the left-hand side of the graph, we're both, we're healthy and functionally active, cognitively stimulated. And then sometime kind of middle age onwards, our health and our kind of functionality starts to slowly decrease. We start to get chronic diseases, injuries, chronic pain, frailty, and then it's a slow, steady decline until the end of our lives. In Canada right now, average lifespan is around 80 years of age. The ideal is to remain more functional for longer. So this line in red. So things that increase our health span can keep us functional for longer, to remain healthy for a longer age, and then keep that period of decline to a relatively limited period. And yes, ideally also expanding our lifespan ultimately. This is a chart that summarizes what has happened to causes of death in Canada over the past 75 years or so. So as you can see, roughly in the 1950s, a lot of cause of death came down to diseases of the circulatory system. So cardiovascular disease was a major cause of death. And that's actually been a fairly, an area of success with our healthcare system. Cardiovascular disease has been declining in terms of a cause of death. It still, of course, happens, but with the advent of more cardiovascular medications, with the advent of more effective medications for cholesterol, blood pressure, treating these risk factors, that's come down. As you can see, though, things like cancer, which is the deep blue line, haven't really changed too much over time. It's remained fairly stagnant, and that's sort of a frontier for our healthcare system at present. When we're talking about all-cause mortality, and this is data from 2016 in Canada, so for that, the total population, what are listed as cause of death, about 30% of that is from cancer, about 20% of that, give or take, is from heart disease, and then a bunch of other causes, as you can see laid out here. So those are kind of the two big ones that are listed as cause of death, cancer and heart disease. When we split that up into age groups, so in a young age group, 1 to 24 years of age, as we can see, a lot of cause of death in that very young age group comes out of things like accidents, unfortunately, things like suicide, homicide as well. When we look at a slightly older age group, so 25 to 44, accidents and suicide are still a big cause of death, but we start to see a little bit of more of things like cancer and some cardiovascular disease that really starts to increase for individuals who are kind of in the 45 to 64 age group, a lot more cancer, double the cardiovascular disease in that age group. And as a cause of death, cancer still remains high in the 65 plus age group, but other diseases really start to accumulate as well and proportionally start to replace it. So what are we trying to do? What is kind of the name of the game here? So the name of the game is avoiding or at least delaying chronic diseases, these diseases that unfortunately are often our cause of death ultimately. The idea being to do so through preventative action and taking early preventative action with lifestyle changes and identifying and addressing our risk factors early on so that we can do something about it before it becomes a major problem, before we're reacting. If we do so, we can avoid kind of, yes, reactionary healthcare, only waiting for the problem to happen before we do something about it. Also, we can remain more functional for longer, aka increasing our health span, and ultimately we can live longer, increasing our lifespan. So before we get into our top 5 tips for maximizing longevity, I wanted to include a couple of assumptions for the average individual. The one assumption is that you're not smoking. So smoking, as if you're not sure by now, is actually probably one of the worst things in terms of statistics that you can do for your health for any number of reasons. So from a cardiovascular perspective, it's a major risk factor for heart disease, stroke, problems with the circulation in the legs. Major risk factor for lung cancer, 25 times increased risk, major risk factor, unsurprisingly, for chronic lung disease, and also major risk factor for cancer outside of the lungs, so much so that 1 in 3 cancer deaths in the States is thought to be attributable to smoking. It's also a major risk factor for things like diabetes, osteoporosis, problems with your eyes, any number of complications. So smoking, if you are still actively smoking, this is probably priority number 1 when it comes to your health. The other assumption is that you're not drinking to excess. So, and the reason I've included this picture here of a swinging pendulum is because the guidelines have kind of changed back and forth over the years as to how much alcohol is safe or recommended. At one point, for example, the guidelines were recommending that it may be beneficial to have a daily glass of red wine. At present, ideally, it's kind of a less is more situation. So the less alcohol, the better, with more stringent recommendations for women compared to men. But what would be considered low risk consumption is about 2 alcoholic beverages per week. The other considerations for the alcohol is that there's actually a lot of calories in alcohol. It's very calorically dense, 7 calories per gram. It's a strong carcinogen, so it has been linked to various types of cancer, like cancer involving the head and neck, breast, colon, liver, and strong links to things like Alzheimer's disease as well. So my 5 tips for longevity. And tip number 1 is daily exercise. Exercise really is the most powerful longevity drug, and it's not a medication. It's free to do. And some science behind this. So people who exercise regularly and are highly functionally active compared to people who exercise very minimally or not at all can live as much as a decade longer. There's no medication that can do that. People who are very cardiovascularly fit are better able to stave off chronic disease, better able to bounce back from illnesses, better able to tolerate treatments, things like chemotherapy if necessary. You remain more functional later in your life, so you have a longer health span if you've been active earlier in your life, and something is better than nothing. So doing just a little bit versus nothing at all can go a long way in terms of reducing your risk. There's, of course, also major benefits from exercise on things like coronary disease, stroke, diabetes, dementia, falls, you name it. Exercise, arguably is the best longevity drug there is. One measure that we use to quantify exercise capacity or measure exercise capacity is this thing called VO2 max. And so this is a test that we do at Almira Medical. This basically involves running on a treadmill or using a bike and exercising nearly to your full capacity. For people who have a high VO2 max, so you're better able to burn oxygen during exercise. People who have a high VO2 max, in order to have that, you have to have healthy heart, lungs. You have to have joints that are working, mechanically able to get to that level of exertion. And also you have to have healthy mitochondria. So these parts of our cells that are kind of our cells' batteries have to be very healthy. VO2 max is something, as you can see in this chart, that declines with age. So if you have a higher starting point for your VO2 max, then that's protective in the long run. And as you can see here, how VO2 max correlates with different activities. VO2 max is something that can actually predict risk of dying. And based on this study, so it's a study in 2023 that looked at how VO2 max or fitness based on VO2 max compares to risk for chronic diseases. As you can see, so this thing called hazard ratio, which is kind of your risk of something happening. If you were in the least fit category, so at the top here, you're at a 4 times increased risk of death compared to someone who's like in an elite category. Even just improving yourself from the least fit category to like a moderate fit category, you can cut your risk of dying in half based on this evidence. So fitness is actually a major predictive metric in terms of how long you may live, and improving your cardiovascular fitness as measured by VO2 max could significantly reduce your risk of death. So something that's worth trying to focus on and measure and improve. Here's a chart, and there are various different kind of stratifications, but here's a chart of how VO2 max can be compared by age and sex. So have a look and see what kind of an average VO2 max or an elite VO2 max is for your age and sex. And ideally, we want to be kind of in those high elite categories. VO2 max is something that we can train, and training does improve VO2 max at any age. It's never too late to start, but it's something that improves slowly. It doesn't improve overnight or after a week of running on a treadmill, for example. Probably takes about 6 months to see a noticeable improvement. How can we train it? There's things like interval training. So once, at most twice a week, incorporating some high intensity intervals. We don't need to do every single day as a max out day, but once a week, ideally incorporating some hard effort that's close but not quite at a level of a sprint, just for 3 to 8 minutes, followed by same sort of periods of 3 to 8 minutes of rest. There's various ways of training our VO2 max in terms of modalities. Often that's running, stationary bike, rowing machine, could be things like swimming. So generally cardiovascular intense exercise. So walking, although walking certainly is better than nothing, unfortunately not enough when it comes to really training our VO2 max. The other thing that gets talked about a lot is something called zone 2 training. So this is referring to a heart rate zone. So based on this chart at the top right, a heart rate zone, for example, that's 60 to 70%. And there are different labels in terms of the percentages. As a rough rule of thumb, your maximum heart rate is generally considered kind of 220 minus your age. So exercising to like 60, 70%-ish of your maximum heart rate, that should actually be the bulk of our cardiovascular exercise. So about 80% of what we're doing for exercise, if you're going for a run, swim, bike, for example, should be at a fairly comfortable pace, a pace where you're able to hold a conversation, but you're maybe not super interested in holding a conversation. And when you look at even the extreme fitness athletes, people like Tadej Pogacar in the Tour de France, they spend most of their time in zone 2 and a smaller proportion, kind of 20%, in that high intensity or VO2 max. So we don't want to forget about strength training or resistance training for lots of important reasons. So lean muscle mass is something that does significantly decline with age, roughly 8 to 17% per decade. It becomes harder and harder to build muscle through resistance training after the age of 65. So we want to start working on that, especially kind of in our 40s and 50s, building up to that time. Muscle strength protects from falls, and falls are a major cause of death in the elderly. Major reason for hospital stay, where people lose function and other things can happen in hospital. When we increase our lean muscle mass, that helps also make us more functional longer. If you think of, for example, like if you were traveling and you want to be an 80-year-old or 90-year-old who's taking an airplane ride, if you have to be able to lift your baggage into the overhead cabin, that takes some extra strength as well. Resistance training helps with our bone growth as well through tension. And we want to focus on things as well with our resistance training that help stabilize us during falls or to prevent for falls. So for example, not just focusing on your hamstrings, but also remembering to focus on your quads, what's called eccentric loading. So that will help us brace from a fall. In terms of stability, this is certainly also important for preventing falls. To put some numbers on the dangers of falls and fractures. So for people who have a hip fracture, 40 years of age or older, there's actually almost a 23% chance of death within 12 months. So that's a very high mortality. We want to avoid falls in an elderly population. So it's very important to remain stable and to have that protective muscle mass as well. Walking alone, again, is a good start, but it's not enough when it comes to strength and stability and reducing falls risk. Often in our elderly population, we're recommending things like Tai Chi or sit to stand or stepping exercises, and having a low threshold to involve a qualified professional, someone like a physiotherapist or kinesiologist, especially if you're going to start resistance training and wanting to make sure that your movements are safe. One last kind of topic on the importance of exercise. Exercise can actually help reduce risk of dementia. This is thought to be through a few different mechanisms, like improving the flow of blood in our brain, improving glucose metabolism in the brain, reducing inflammation and oxidative stress, and helping produce this thing called BDNF, or brain-derived neurotrophic factor, which helps in this part of the brain called the hippocampus, which is involved in memory. One interesting study looked at the correlation between grip strength and dementia, and grip strength being kind of a proxy for kind of exercise fitness and muscle mass as well. And so for people who scored in the bottom 25% for grip strength, they had a 72 higher percent chance of dementia. And it's thought that, this poor grip strength is thought to be kind of a marker of frailty. So this is not to say if you do a whole bunch of, isolated hand squeezes, you're not going to have dementia, but it's just certainly a reinforcing factor that exercise and strength training and staying physically active is actually protective from dementia. All right, so that's tip number 1 of 5. Longevity tip number 2 is talking about diet. So replacing carbohydrates with lean protein and vegetables. And again, if there's any questions, I can answer them at the end. So there's a lot of misinformation out there when it comes to diet. There's a lot of fad diets. There's a lot of terms that get thrown around. It's hard to know what's legitimate. It's hard to know what's worth pursuing. It's hard to know what has evidence. So I want to try and simplify some of that for you today. And the general trend, again, is replacing carbohydrates with lean protein and vegetables. So carbs. Carbs have become increasingly kind of the modern staple of our diet, when in the past they actually were very small proportion of our diet. We don't really need much, if any, carbohydrates to get through our day as humans. Carbs as a general category of food or macronutrient often are fairly limited in their nutritional value. Carbs are a ready source of energy. Carbs, not every carb is created equal, but often can have fairly minimal fiber, often can make it difficult for us to feel full after we consume carbohydrates. There are also issues with excess carbohydrates when we're not burning them off right away. These excess carbs are readily stored as fat in our body. When we're having, quickly metabolized carbs, so what we call like high GI or glycemic index type carbs, these create big spikes in our blood sugar, which also then leads to big spikes in our insulin. And this is a major mechanism, as we'll come on to, which correlates with things like diabetes and insulin resistance. Often what goes hand in hand with our modern carbohydrates are these things called ultra-processed foods, which you may have heard of. So most foods, unless you're grabbing an apple off the tree, for example, most foods are processed to some degree, and that may just involve, for example, just chopping something up or putting in a can, like a canned sweet corn. But we start to potentially get into trouble when we go into the ultra-processed domain. So that's, if you think of it as a lot of additives, preservatives, chemicals that are added to our food to either make them last longer or taste better or have a texture that's preserved for longer. Often, if you're looking at labels, these are often ingredients that you may not recognize. It's not, for example, water or wheat. You may be coming across lots of strange chemical compounds that you don't know. If you have one of those, chances are it's an ultra-processed food. Lots of potential issues, and we're learning more about this recently, but lots of potential issues with ultra-processed foods. They're, generally speaking, a lot of empty calories with limited nutritional value. Often they have high saturated fat, high sugar, high salt, often all three, which makes it, of course, very difficult for us to resist these foods, difficult for us to feel full. We keep eating even just because we enjoy the taste of it. It increases things like colorectal cancer, for example, 29% increase in men. There's associations with coronary disease. And there was a Harvard study that showed in women there's a 50% increased risk of depression. How do we get around this? With things like cooking at home more often, limiting snacking outside of mealtime, and the old adage of, sticking to the periphery or the outside of the grocery store. So things that need some refrigeration are less likely to be ultra processed. Start having a look at labels. And again, if you're seeing a lot of ingredients that you don't recognize, there's a good chance that is ultra processed. If it can stay in the aisles of the grocery store for 10, 20, 30 years, and there's a good chance that's ultra processed as well. Protein. So we want to try and replace our carbs and these ultra processed foods with protein, and specifically lean protein and also vegetables. There's a few reasons why. So protein leaves you feeling fuller through this suppressing release of a hormone called ghrelin, which is a hunger hormone. Protein itself is anabolic. So if you're eating protein, that helps you kind of keep and some potentially even increase muscle mass. There was a study that looked at giving a healthy aging study and showed that those in the top 20% of protein consumption kept more muscle mass than people who were in the bottom 20%. There's different recommendations out there. So the current US recommended dietary allowance is having around 0.8 grams per kilo of body weight of protein. There's some conflicting evidence that probably shows that, giving that amount of protein to elderly people, they actually lose muscle mass. Generally speaking, probably the average Canadian is eating too little protein. The Canada's Food Guide says protein should make up a quarter of your plate, which is somewhat arbitrary. To gain muscle mass, we may need as much as 1.6 grams per kilo. A general rule of thumb, so that's about 1 gram of protein for every pound of body weight is probably a good amount. When we get into the excess or too much protein area, that's probably in the range of 1.7 grams per pound. So that's a lot of protein, especially if you consider. So for 25, pardon me, a chicken breast, that's roughly speaking 25 grams of protein. So rule of thumb is we're probably as a society underdoing it on the protein and overdoing it on the carbohydrates. Vegetables, we've been told since a young age, eat your vegetables. And there's, of course, lots of good reasons why this is the case. In contrast to carbohydrates, generally speaking, vegetables are more nutrient dense and calorie light. They have lots of essential vitamins, vitamin A, C, E, K, B9, which is folate, lots of essential minerals, potassium, magnesium. Vegetables, generally speaking, have good fiber content, which is good for our gut health and helps us feel full. And then there's also these things called phytochemicals, which are very present in colorful vegetables, which have some antioxidants and anti-inflammatory properties. For people, though, who are eating just a strict vegetable or plant-based diet, so for example, vegans, there are some things that you need that you're not getting. Let's say if you're not eating meats, if you're not eating dairy products, so you may consider supplementing with things like vitamin D, calcium, B12, iron, which of course is readily present in red meats, omega-3s, for example, in fatty fish, and some other stuff like zinc and selenium, for example. When we look at diet and dementia, and which diets help reduce or the risk of dementia are recommended, there's a lot of degrees of overlap. The two most common ones, the ones that keep popping up, are these things called a Mediterranean diet and also this thing called the MIND diet. A lot of similarities. Generally speaking, more fruits and veg, more lean protein like nuts, seeds, chicken, and fish, less of things like the heavy animal fats like cheeses, butters, red meat, and keeping things like pastries and sweets once in a while, sort of occasion. Okay. That's our second longevity tip. Moving on to number 3. The third tip is to prevent cardiovascular disease by focusing on your risk factors. And the big ones here are your blood pressure, your cholesterol, your blood sugar, and your body fat percentage. So if you know what these numbers are and can control these numbers, you stand a very good chance over the long term of preventing cardiovascular disease, which is, again, things like heart attacks, strokes, heart failure. So the basic mechanism that underlies a lot of cardiovascular disease, if you think of a heart attack, for example, is this thing called atherosclerosis. As many of you already may understand, this is, in layman's terms, like clogging of your arteries through cholesterol-rich plaques. These plaques do not happen overnight. They build up slowly over years and more likely decades. Any artery can become affected. So the arteries in the heart, when they're affected, the coronary arteries, that can cause a heart attack. The arteries in the brain, that can cause a stroke. Can affect kidney arteries, for example, arteries in your legs, causing circulation issues. We know what causes atherosclerosis and cardiovascular disease. The big ones, again, smoking. So if you're still smoking, now is the time to stop. High blood pressure, hypertension, high cholesterol, diabetes, obesity, and sedentary lifestyle. Well, these are kind of our modifiable risk factors. There are, of course, some things we can't change, family history, genetics, age, you name it. So we want to focus on the things that are within our control. Again, so when we have an event like a heart attack, this may seem sudden, this may happen, one day, but it really is the culmination of essentially decades of buildup, in most cases, of plaque in the artery that one day rupture, the straw that broke the camel's back. When these atherosclerotic plaques rupture, as seen in the diagram here, you can get a blood clot that forms around the rupture, blocking the artery. This is why, for example, we often give antiplatelet agents like aspirin in the treatment of a heart attack to reduce the formation of that blood clot. This process, though, is predictable. It's more predictable and preventable than cancer or dementia. So we can see these plaques on imaging studies like like the coronary arteries, for example. Once they start to cause flow issues, that can cause angina, so heart pain. And one test that we do here is our cardiac stress testing. And if you're having anginal symptoms, you may have a positive stress test. So this is something that we understand and can, with enough of a time horizon, prevent. Other risk factors for cardiovascular disease, or actually, rather, I should say, the first major risk factor we want to talk about specifically is high cholesterol. In general, we kind of oversimplify cholesterol by cutting it into, good and bad. And good gets labeled as HDL cholesterol and bad gets labeled as LDL cholesterol. And it's actually really not the cholesterol itself. What we're really talking about with HDL cholesterol and LDL cholesterol is actually the things that carry cholesterol. They're called lipoproteins. And there are some good lipoproteins and bad lipoproteins. And those are kind of on the diagram on the right. So at the top is HDL. You'll notice the HDL molecule doesn't have a little black circle around it, the ApoB particle, whereas all the other ones are kind of ApoB type molecules. The most common one is the LDL particle that everyone checks for, but that's not the only bad actor. And sometimes if we only look at LDL cholesterol, we can miss other things that can cause issues. When it comes to treatment of cholesterol through lifestyle changes, this is one area that's slightly less amenable to lifestyle changes. So exercise, unfortunately, doesn't have a major impact on reducing cholesterol levels, although exercise is very important for preventing cardiovascular disease, improving longevity, as we talked about. Things that can help is aggressively reducing our carbohydrate intake and our saturated fat intake, but these kind of help only to a modest degree. So oftentimes there is somewhat of a genetic component, and oftentimes when we're treating cholesterol, we do need a medication. And thankfully, medication can be very effective in addressing high cholesterol, specifically these ApoB type of proteins. Eating too much cholesterol is really not the problem. So people often ask, am I eating too many eggs? Is that why my cholesterol is high? That's really not the case. And because in humans, when we have too much dietary cholesterol, we actually just poop it out, basically. But from a diet perspective, as mentioned, excessive carbohydrates and excessive saturated fat, if we can address those, that can help to a degree. And the reason for the carbs is that actually when we eat too many carbs, this gets readily converted to triglycerides. And triglycerides need to be carried around the bloodstream by these, lipoprotein molecules that also carry cholesterol. Excess saturated fat. So again, saturated fat being things like heavy animal fats, like beef, cheese, cream, butter, lard, that sort of stuff, and also certain oils like palm oils, coconut oils, for example. The types of fats that are generally speaking, good would be things like olive oil, extra virgin olive oil, specifically avocados, macadamia nuts. These are high in more unsaturated fats. Thankfully, a type of fat that's generally speaking outlawed, at least here in Canada, is like trans fats. Those are a type of fat that we really want to try and avoid, but it's harder to find even if you're intentionally looking for it. Lipoprotein A, so this is a type of lipoprotein that is actually a bad actor that we often miss, and we try and send it here on every patient, every client. Lipoprotein A, so this is a molecule that's less prevalent or less commonly found than, let's say, LDL, the lipoprotein, but is much more likely to cause clogging of the arteries. So it's up to 6 times more of what we call atherogenic compared to an LDL cholesterol. It is a cause of heart disease, often in younger individuals. It also is destructive to the aortic valve in your heart as well. It's strongly genetic, so roughly 90% of the reason why lipoprotein A is high is through genes, and it's what we call autosomal dominant. So if you have it, there's a 50-50 chance that any sibling or child can also be affected. It's more likely to be elevated in Black and Asian individuals. Everyone should have their lipoprotein A checked once in their life. And if it's normal, then you pretty much never have to check it again. It's not part of your standard lipid profile test. You have to ask for it. It is covered in Ontario, and it doesn't need to be a fasting blood test. Unfortunately, lifestyle changes have a fairly minimal effect on reducing lipoprotein A, so maybe a very mild degree of lowering from carbohydrate reduction, reducing levels by up to 15%. Right now, we don't have great medication options, but thankfully they are being developed. So these things called small interfering RNAs or siRNAs show very promising results, lowering by as much as 90% for one agent and one trial. But unfortunately, we're going to have to wait a couple of years. So everyone should get this checked once in their life. But unfortunately, right now, there's not a huge amount we can do for it if it's high, apart from waiting for these medications to become available. Hypertension, of course, I spend a lot of time talking about high blood pressure, but why do we care about high blood pressure? It's a major risk factor for stroke. Roughly half of strokes are from the high blood pressure. Major risk factor of heart attacks, heart failure, kidney failure, problems with the circulation, legs, dementia, you name it. So we want to treat high blood pressure, and it causes damage over the long term. So in terms of targets for blood pressure, for an average risk individual, currently in Canada, that's less than 140/90. We are due to have some new guidelines released very shortly, so we'll see if that changes. For someone with diabetes, it would be a target of less than 130/80. And for certain high-risk individuals, we may consider a more aggressive target, less than 120. For those of you who have come to the hypertension clinic, you may have seen this chart. So this is how blood pressure changes with age. The lines in red are women, and the lines in blue are men. The top lines are what we call systolic blood pressure, so the top number, let's say 120, for example, and the bottom lines are what we call our diastolic blood pressure, so the 80, for example, and a normal blood pressure. As you can see, earlier in life, women have a lower blood pressure than men, and this starts to go up faster around menopause years. But both for women and men, this increases steadily with age. This is as our blood vessels become more thick and calcified and less stretchy. And unfortunately, we don't have any great medication that can reverse that process. Just as the skin changes with age, so do our arteries change with age. For the bottom number, the diastolic blood pressure, slightly different story. This actually reaches on average a maximum of about 55 years of age, and it starts to come down. So it's very common for someone in their 40s for the numbers to be close together, and someone in their 80s to have a very high systolic blood pressure and a low diastolic blood pressure, a big difference between the two. Both numbers are important to control though. And when it comes to lifestyle changes for high blood pressure, as many of you will know, the diet that has the best evidence is this thing called the DASH diet. Lots of fruits and veg, fiber, low fat dairy products, and lean protein, things like chicken and fish. So again, lots of overlap with things like our MIND diet, Mediterranean diet, low sodium as well. And some people have blood pressure that disproportionately goes up with sodium. Recommended maximum for someone with hypertension would be 2 grams or 2,000 milligrams per day. The average Canadian probably has 3,000 or more milligrams of sodium. Keeping weight down can really help, or losing weight can really help with reducing blood pressure. Exercise can certainly be helpful as well for reducing blood pressure, and is generally speaking safe for people with high blood pressure. And other things like reducing alcohol, smoking cessation, again, relaxation techniques. These are kind of the lifestyle changes for high blood pressure. For diabetes, this is another major cardiovascular risk factor. And the main issue with diabetes, or really the underlying principles, is either too little insulin or resistance to insulin. So type 1 diabetes, the body isn't making enough insulin, and often this can start at a very young age. And the treatment is with basically lifelong insulin treatment, whether as injections or insulin pumps. And type 2 diabetes, it's resistance to insulin. So the chart on the right shows what happens with your insulin for someone who has type 2 diabetes as they get older, so throughout the decades. As you can see, earlier in life, one is very sensitive to insulin, and only a small amount of insulin can help tuck sugar into your cells or tissue. But if we keep asking the pancreas to give more and more and more insulin, so if you keep having these high spikes of sugar, which lead to high spikes of insulin, eventually the body becomes resistant. To make matters worse, your pancreas kind of gets tired as time goes on, and eventually its ability to give out more insulin goes down. So the treatment for a lot of people with type 2 diabetes eventually is with insulin injection ultimately. So we want to prevent that process well before it gets to that sort of point. In terms of numbers and diagnosing diabetes, the kind of the most common way of diagnosing diabetes at present is through a blood test called HbA1c, which is a measurement or a proxy of your blood sugar over a few months. For someone who has a score that's like 6 to 6.4%, that's called prediabetes. Diabetes is labeled as a HbA1c of 6.5% and up. But we want to do something well before we even get to the prediabetes sort of levels. Why do we care about diabetes? What are the complications? So what we consider saying a specific complication of diabetes, the kind of three of the big ones would be like affecting the blood vessels in your eye, so what we call a diabetic retinopathy, which can ultimately lead to blindness. There's a photo on the top right. Diabetic nephropathy, or diabetes affecting the kidneys, which can lead to needing dialysis, which is this gentleman in the middle, and also affecting our nerves and our sensation. It can lead to things like diabetic foot ulcers and unfortunately things like amputation. But there's dangers with insulin resistance alone, even before a diagnosis of diabetes. So insulin resistance increases the risk of cancer by as much as 12 times, which is pretty staggering. Increases risk of Alzheimer's by up to 5 times, increases risk of cardiovascular disease up to 6 times. So insulin resistance, which is the hallmark, again, of type 2 diabetes, is a major concern. We don't want to wait till it's too late. We want to do something well before that point. Along with diabetes is a commonly associated condition, just obesity. And as a society, we are becoming increasingly obese. So this data is from roughly 2018. As you can see, at that time, roughly 28% of Canadians are obese. Slightly less than our counterparts down south, but certainly as a country, we're up there. And one of the main concerns with obesity is where we have to put the fat. So if we're chronically overeating, if we're in chronic caloric surplus, we're putting in more calories than we're burning, our body has to find places to put this. So it can put it in under our skin, what we call subcutaneous fat, which can be, generally speaking, considered safe, but different individuals may have different ability to tuck fat into that compartment. Unfortunately, a lot of fat ends up surrounding our organs, what we call visceral fat, which you can kind of conceptualize as an overflow parking lot. And this fat surrounding our organs can be very damaging. When fat gets into our liver, for example, causing fatty liver disease, this can eventually cause cirrhosis or irreversible scarring of the liver. And there's major correlations between things like visceral fat and cancer risk and cardiovascular disease as well. Here at Almira Medical, we have this scanner called the Body Scan. It uses different technologies to try and give us not only a body fat percentage, but also can tell us how much fat is in subcutaneous versus visceral fat compartments. The gold standard is kind of essentially X-ray, so DEXA scans. For those of you who have had bone density testing, that's sort of the gold standard. But the body composition scan that we use has over 95% sensitivity and specificity compared to that. All right, longevity tip number 4 is to remain cancer vigilant. Okay, so here's one of the major concerns with cancer. This is showing some common types of cancer and your likelihood of survival based on the stage or extent of the disease. As you can see, when we have cancers that are very advanced, or what we call stage 4 disease, it becomes much harder and much less likely that we're able to survive it. Whereas when we identify cancers early on, stage 1 disease, those are much more curable. We're much more likely to be able to survive that. Some cancers are, of course, more deadly than others. Take, for example, prostate cancer, unless it's very advanced, often has fairly good survival. Some challenges in our current kind of cancer landscape. Cancer is much less predictable than cardiovascular disease, excuse me, and bad luck has a major factor, a major role to play. You can have a perfect diet, you can exercise a lot, you can avoid toxins your whole life. Unfortunately, this still is not guaranteeing that we avoid cancer. Most cancers can only be detectable, or a lot of cancers rather, only give you signs or symptoms when the disease is fairly advanced, in which case, you have to do screening tests very, very regularly to try and pick it up. And screening tests, as we'll come on to, each has their own kind of pros and cons as well. And these tests are not perfect tests. They're not 100% sensitive or specific. They have issues with like false negatives or false positives. Treatment. So treatment with surgery is typically only an option for fairly local disease. Most metastatic cancers, unfortunately, when they're identified, are at a point that's called palliative, aka they're not curable, but they can only be slowed down. Chemotherapy is often used, but chemotherapy kills more than just the cancer cells. It often kills our native cells, and not everyone can handle a chemotherapy. And there's never really going to be a single cure for cancer. Cancer, yes, is an umbrella term, but between lung and prostate cancer, these are two very different diseases. And even between different types of lung cancer or a same type of lung cancer in two people, these are all very different diseases that may require different treatments. So there's no single agent that works for everyone. How can we prevent cancer? These are kind of the biggest things that are available to us. So one is stopping smoking if you are smoking. And again, as a reminder, smoking can cause cancer pretty much anywhere in your body. Getting metabolically healthy, so losing weight if you're obese, avoiding insulin resistance, as we touched on, up to a 12 times increased risk of cancer. And those who are metabolically healthy as well, as we mentioned, are better able to handle cancer treatment, like chemotherapy, for example, if needed. We want to protect our DNA from mutation, so avoiding sun exposure, especially repeated burning episodes, especially earlier in life. And we want to avoid excess or any kind of carcinogens when we can as well. Obesity and cancer, and I think this is something that generally speaking is underappreciated. Obesity is actually considered to be the second biggest risk factor for cancer. And roughly, 12 to 13% of global cancers are thought to be related to obesity. Obesity increases lots of different types of cancers, as you can see in the picture on the right. And those with type 2 diabetes, which often goes hand in hand with obesity, doubles the risk of pancreatic cancer. So chronically high insulin levels or insulin resistance, as mentioned, does also play a big role, as recent studies have shown, in cancer and metabolism. Sun exposure and skin cancer. So here are some different types of skin lesions that you should be on the lookout for. So in the top left, basal cell carcinoma. This is kind of basically a mild form of skin cancer, often relatively harmless, but still needs to be addressed, and doesn't really spread anywhere, and often can be cut out. On the right, we have squamous cell carcinoma. This is a more dangerous sort of cancer, which can more readily spread if we don't cut it out. Bottom left, we have what's called actinic keratosis. So this is kind of a precancerous lesion. And on the bottom right, we have an example of a melanoma. So something that, as you can see, is kind of blotchy and has irregular borders, has different colors or consistencies within it. So certainly be on the lookout for this one. I recommend people take pictures of their moles and stay vigilant. Don't ignore changes in your skin. And, I have a low threshold for these kind of changing moles for referring to a dermatologist who may often freeze or remove them entirely. In terms of cancer red flags, so the big one to be on the lookout for is unintentional weight loss. So pretty much any cancer at a certain stage can cause unintentional weight loss. Think, for example, you lost 20 pounds in, a few months with no explanation why. That for me is a red flag that needs urgently working up. And then I've included here other some other red flags for specific types of cancer. So for colorectal cancer, that's things like blood in the stool, change in bowel habits, abdominal pain and swelling. For cancer involving the esophagus, that's pain when swallowing or new difficulty in swallowing. For the pancreas or gallbladder, that's things like painless jaundice, so yellowing of the skin or the eyes. For lymphoma, that's things like drenching night sweats, fevers, or weight loss, which are often referred to as our B symptoms of lymphoma. Bladder cancer, a red flag would be like unexplained blood in the urine. And lung cancer, as the movies often depict, would be something like coughing up blood, shortness of breath, so on and so forth. Cancer screening pros and cons. So the case for early screening is that, again, when we catch cancers earlier on, this significantly increases our chances of survival and that we can do something about it, like surgery, for example, whereas metastatic cancer is often typically incurable. The case against screening, so everyone having testing all of the time, is that there's often a lot of false positive results or other incidental findings that come up that us as healthcare providers have to make a decision about what to do about or what to recommend doing. So things like biopsies if needed, which are invasive tests, often more scans, so CT scans, which can involve radiation. And when we can overdiagnose cancer. So an example of this would be like prostate cancer. So actually somewhere in the realm of like 80% of 80-year-old men have prostate cancer, but most men die with prostate cancer, not because of it. So it's something that is present, but is actually in a lot of cases, most cases, is really not causing massive issues. So, but when we screen everyone, we're picking up on a lot of stuff which may or may not have caused the problem in the long run. Some specific cancers, we got breast cancer, cervical cancer, and ovarian cancer in women. So 1 in 8 women will develop breast cancer. Higher risk from things like BRCA1 or BRCA2 mutations. For women who are 50 to 70, the current recommendation is mammograms every 2 or 3 years. Cervical cancer, I would consider this an example of an effective screening program through pap smears, starting at the age of 25, typically every few years. And then from the age of 70 on, kind of depending on your prior results. There's really not a great ovarian cancer screening protocol in place. Here's kind of the standard Canadian screening checklist, like a minimum checklist. For both sexes, should involve colonoscopy. This really should be at the latest starting at the age of 50 and often earlier for people who have a strong family history. And the earlier we can pick up a cancerous polyp, the better. Colonoscopy is very effective for screening for colon cancer. We talked about the female-specific recommendations. For men, PSA is it's a blood test that at present, it depends on who you ask. It's often a conversation. There are issues with sensitivity and PSA. So at present, from a Canadian recommendation standpoint, it's kind of a weak recommendation about thinking about it or talking about it with your doctor. Whole body MRI. So this is something that's growing in popularity as kind of a private option. The rationale being, if we can screen the whole body and looking for cancerous lesions or changes or tumors, the earlier we pick that up, the better. With MRI, there's no radiation. This test doesn't involve any injection. As mentioned, it's growing in popularity. You get people like Kim Kardashian here who are endorsing it. There are a couple of places in Ontario where you can have this done through a referral. What I would say for anyone who wants to go through with this is just understanding some of the trade-offs and potential risks. So whenever you do an MRI of the whole body, you're going to find some stuff that probably would never have caused issues in the long run. And it leaves us with the question of what do we do about it? Do we need to biopsy? Do we need to CT? Kind of these incidental findings. A whole body MRI is a little bit less detailed than doing an MRI, let's say, for example, of the knee, which may take half an hour, and a knee MRI, but a whole body is only an hour. So it's a little bit quicker, maybe a little bit less sensitive, with the potential, therefore, to miss something. This may lead to over-diagnosing things. We mentioned, for example, prostate cancer. We may identify very slow-growing cancers, which may not have been an issue. There is a psychological element. Some people may not want to know about all your internal imperfection, and there's not overall huge evidence that doing this at a big population level may lead to additional concerns. One cancer I just wanted to single out is pancreatic cancer. This is certainly something that gives me pause. Here are some examples of some people who have been affected and sadly passed away as a result of pancreatic cancer. Beck, Ruth Bader Ginsburg, John Lewis. Should also include on here Steve Jobs, for example. The sad thing about pancreatic cancer, it is one of those cancers that really, once you start to get symptoms like jaundice or yellowing of the skin or unexplained weight loss or really abdominal pain, often it's quite advanced at the time of diagnosis. And it's a very deadly cancer that at present has unfortunately very low survival rates as a result. There is a blood test called CA19-9, which in theory could be used as a screening test, but not great in terms of its sensitivity, only high in about 70 to 80% of people with pancreatic cancer. The most sensitive test would be doing something like an MRI of your pancreas. So I'm curious if there's a role for this at a population level over in the future. But of course, that'd be quite resource intensive doing that on a regular basis for the whole population. One thing I'm excited about, so this is an emerging technology, is something called liquid biopsies. So which is considered like a blood test, which you can do to screen from multiple different types of cancers at the same time. The technology is focused on something called cell-free tumor DNA. The idea is that these cancers or tumors are constantly shedding cells, which have kind of their DNA fragments, and these float around the bloodstream. And if we do a blood test that picks up on these DNA fragments, and you have one type of thing that is sky high, then that might lead you to doing specific imaging tests sooner than you would otherwise. So screening asymptomatic people. This is something that currently is available in the States. They're doing a large trial for this in the UK right now at a population level. It has pretty good, what we call positive predictive value. And so, for example, a positive predictive value, or the likelihood that you have a positive test, if that actually means you have cancer. For a mammogram, that's actually only 5%, so very low, but for something like this, it's closer to 40%, so relatively good. Also, if you have very active cancers that are shedding a lot of cells, turning over, growing quickly, those are more likely to be positive on the test. And tumors that are less active or very slow growing are less likely to be positive. So some good, some bad in that regard. There is also issues with, specificity versus sensitivity. So how sensitive do we want it? If you think of it like a metal detector rather in the airport, do we want it to be positive in everyone or only in certain cases? So there's going to be some calibration that's needed with time. My current understanding is this test is probably a few $1,000s and can be arranged in Canada if needed, but is generally speaking not available to the general public. All right, so if you're still with me here, we're up to longevity tip number 5, which is protecting your memory with quality sleep, social engagement, and complex tasks, so aka prevention for dementia. What can we do? So dementia really is an umbrella term or an umbrella category, and there are specific diseases within that. So Alzheimer's disease is the most common cause of dementia, so 60 to 70% of dementia cases, but it's not the only one. There's other things like vascular dementia, frontotemporal dementia, Lewy body, so on. Dementia is progressive. Dementia is irreversible. So it's important that we do as much as we can to prevent it up front from an early age. Once you have a diagnosis of dementia, at present, we can't cure people of dementia. There's this commission, so it's from the Lancet, so a big UK journal that gets released every once in a while, looking at what we can do to modify or reduce dementia risk. And their most recent commission in last year came out saying that dementia risk is thought to be about 45% modifiable, so something that we can do about. And as you can see here, earlier in life, things like education can play a role in dementia development. Things like in middle life, like hearing loss, cholesterol, depression, brain injury, can have major roles in dementia. And controlling as well your cardiovascular risk factors. So what is good for your heart is thought to be good for your brain as well. We talked about exercise, insulin resistance, for example. And later in life, things that we want to focus on are social isolation, things like pollution, vision loss, and also middle life hearing loss as well. Those are kind of the modifiable risk factors for dementia. Here these things are kind of represented in other terms. So these are what we can do to prevent dementia on the left, and then in the middle in red is the mechanisms, how that helps, with the ultimate goal being preventing and delaying dementia. What we can do as well is building up a cognitive reserve to defend against dementia. So basically, the more kind of neural pathways that we have in place, the more that we've used our brain through things like complex tasks, like learning languages, having very stimulating intellectual activities, playing the piano, learning new instruments, for example. These things are protective against dementia for the longer term and can help in reducing or slowing the progression from what we call mild cognitive impairment to ultimate dementia as well. Sleep and dementia, this is something that is greatly undervalued, the importance of sleep, and specifically a stage of our sleep called deep sleep. This is kind of where a stage of our sleep, usually early in the night, where it's thought that waste products are kind of swept away. There is an association between chronically poor sleep, especially in middle ages, kind of 40s to 60s, and dementia risk. And there's what we call a U-shaped distribution. So for people who get less than 5 hours of sleep per night or more than 10 hours per night, either of those extremes are associated with dementia risk as well. So kind of the 7 to 9 hours, give or take, is kind of, so to speak, ideal sleep. When it comes to medications and sleep, this could be a whole other talk, and chronic insomnia. Most sleeping pills, unfortunately, they're good at knocking us out, but not necessarily giving us deep sleep. Things, for example, like Zopiclone, for example, also benzodiazepines, so lorazepam, diazepam, Clonazepam. These also increase our risk of dementia and falls and car accidents. One or two medications which are, generally speaking, a little bit safer and can help with sleep and what we call sleep architecture. So maintaining a good deep sleep is things like trazodone is a better option, for example, compared to Zopiclone, and also commonly something like melatonin, for example, as well. All right, so putting it all together, my 5 top recommendations in terms of things that you can do to maximize your longevity. Number 1 being exercising daily. This, from my perspective and looking at the statistics, can be considered the best longevity drug that we have. Number 2 would be replacing carbohydrates with lean protein and vegetable. Number 3, controlling your cardiovascular risk factors, so things like blood pressure, cholesterol, blood sugar, and body fat. These are kind of the major risk factors for cardiovascular disease that we should monitor and do something about. Number 4, remaining cancer vigilant, so watching out for those red flag symptoms, going through the appropriate screening processes, taking your individual risk into account. And number 5 is protecting your memory. So again, sleep, quality sleep specifically, social engagement, complex tasks, doing what you can early in life to prevent dementia, because sadly, once you have a diagnosis of dementia, there's already been some damage that's been done,
and is generally speaking an irreversible condition. All right, I just wanted to take 1 minute to talk about Almira Medical, which we briefly mentioned at the beginning, and also you've been seeing that name on the slides. So this is a private medical clinic that I've created focused on maximizing longevity, really focusing on lifestyle-based interventions and preventative care, what we call comprehensive disease prevention. What we offer, so is comprehensive health assessment, so physician-led, long form visits to really do a deep dive on someone's health, identify and start addressing any areas of concern for longevity, whether that's cardiovascular disease, metabolic health, cancer risk, dementia risk, those sorts of things, preventing chronic disease. We do in-house testing, so VO2 max, like we were talking about, body composition scanning. We make use of the cardiac testing in the office as well. And then we come up with like a personal health plan. So a lifestyle-based plan focusing on dietary and exercise-based interventions, a plan that incorporates cancer screening, dementia prevention planning, and also looking at medication and supplement adjustment. We provide on-demand care, so year-round care, flexible follow-up visits, and assistance from a dedicated healthcare coordinator as well. If you're interested, here is the website. You can have a look and see what have a look at our services, and we'd be more than happy to chat with anyone who wants to talk about this further. Okay, so if you're still with us here, I'm going to open up for questions.